Welcome to this pharmacology series. I'm Dr. Deborah Osei-Sarfoh. I teach diseases and medications, one drug, one mechanism and one animation at a time. Let's learn about the coagulation cascade and anticoagulants. In the previous video, we covered the body's response to injury, starting with vasospasm, followed by platelet plug formation, and ending with the coagulation cascade. This video focuses on the coagulation cascade, also known as secondary hemostasis. Blood coagulation is the conversion of liquid blood into a clot. You can think of it like a burst pipe. The first thing you do is slap on a clamp or rubber patch to stop the leak. That's the platelet plug. It works fast, but it's fragile. Then you weld over it, melting metal to seal and reinforce the pipe. That's the coagulation cascade. The entire process is aimed at converting soluble fibrinogen into insoluble fibrin mesh, forming a stable clot. Fibrin formation occurs in two pathways. The intrinsic or contact pathway, which is activated by damage to the blood vessel by artificial surfaces like glass or highly charged materials, and the extrinsic pathway, which is activated by tissue damage. In reality, clotting in the body operates as a single unified pathway, where both converge to form a stable blood clot. The extrinsic pathway serves as the rapid first responders, triggered by tissue injury to initiate clotting. The intrinsic pathway acts as the supporting amplification system, slower acting but essential for reinforcing and maintaining the clot. The components involved in this process are known as factors. The clotting factors circulate in blood as inactive precursors called zymogens. When activated by proteolysis, they become enzymes, labeled with the suffix A. Each activated factor triggers the activation of many more molecules in the next step, creating a cascade that amplifies the clotting response and rapidly leads to clot formation. Negatively charged phosphatidylserine on the platelet plug activates floating inactive factor 12, and this triggers the intrinsic pathway. Factor 12A then activates factor 11, which then activates factor 9. Factor 9 then interacts with factor 8, platelet factor 3 and calcium as a cofactor to form a complex. This complex then activates factor 10. The active form of 10 interacts with factor 5, platelet factor 3 and calcium. This complex activates the prothrombin activator. Prothrombin activator converts factor 2, also known as prothrombin, to thrombin. Thrombin then converts soluble fibrinogen to insoluble fibrin. Thrombin also activates factor 13, also known as the fibrin stabilizing factor. Activated factor 13 cross-links the fibrin strands to form a fibrin mesh. Tissue damage initiates the extrinsic pathway by releasing factor 3, also known as tissue factor. Factor 3 reacts with factor 7, which in the presence of calcium, undergoes active site transition. The tissue factor 7A complex then joins what is referred to as the common pathway by activating factors 10 and 9. Take a brief moment and study this to help you remember the coagulation cascade. Natural anticoagulants exist to limit coagulation to the site of vascular injury and prevent excessive clotting. Heparin sulfate binds antithrombin 3, which inactivates clotting factors 2, 9, and 10. Another protein, thrombomodulin, binds to factor 2 and activates protein C with cofactor, protein S, degrades factors 5 and 8. Anticoagulant drugs inhibit either the action or synthesis of the coagulation factors. Heparin is a rapid-acting injectable anticoagulant derived from porcine intestinal mucosa. Unfractionated heparin is a heterogeneous mixture of anionic glycosamine chains with variable molecular weights. Low molecular weight heparins are smaller fragments, 1/3 the size, produced by depolymerization of unfractionated heparin, and are increasingly used clinically due to fewer drawbacks. Heparin increases the rate of antithrombin-mediated inactivation of coagulation factors by approximately 1,000-fold. Heparin and low molecular weight heparins both act by accelerating antithrombin 3 but differ in factor specificity. Unfractionated heparin enhances antithrombin 3 inhibition of factor 10 and thrombin, while low molecular weight heparins primarily enhance antithrombin 3 inhibition of factor 10, with less effect on thrombin due to its shorter chain length. Heparin has a rapid onset and short duration of action but is increasingly replaced by low molecular weight heparin due to subcutaneous weight-based dosing, predictable pharmacokinetics with minimal monitoring, and reduced healthcare costs. Major complications of heparin include bleeding complications, which is managed by stopping heparin or giving protamine sulfate. Hypersensitivity reactions, thrombosis with chronic intermittent use, and thrombocytopenia. Fondaparinux selectively inhibits only factor 10. By selectively binding to antithrombin 3, it potentiates the innate neutralization of factor 10 by antithrombin 3. Fondaparinux requires less monitoring than heparin and may be used in patients with heparin-induced thrombocytopenia. Direct thrombin inhibitors act by directly inhibiting factor 2. Argatrobin is monitored using the activated partial thromboplastin time, a blood test that measures how long it takes blood to clot. Direct-acting oral anticoagulants include apixaban, dabigatran etexylate, edoxaban, and rivaroxaban. Dabigatran is a reversible inhibitor of factor 2. Apixaban, edoxaban, and rivaroxaban are reversible inhibitors of activated factor 10. These are used for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. Rivaroxaban is also used for the prevention of atherothrombotic events in patients with coronary or peripheral artery disease. Warfarin is an oral anticoagulant that antagonizes vitamin K. Several coagulation factors 2, 7, 9, and 10, as well as proteins C and S, require vitamin K as a cofactor for hepatic synthesis and undergo vitamin K-dependent carboxylation. During this process, reduced vitamin K is converted to vitamin K epixide, which is normally regenerated by vitamin K epixide reductase, the enzyme inhibited by warfarin. Unlike heparin, warfarin has a delayed onset of about 8 to 12 hours with peak effects at 72 to 96 hours. Its anticoagulant effect can be reversed with vitamin K, but reversal takes approximately 24 hours. Warfarin's principal adverse effect is bleeding, for which it carries a black box warning and requires close INR monitoring. Minor bleeding is managed by stopping the drug and giving oral vitamin K, while severe hemorrhage requires intravenous vitamin K and possibly blood products or clotting factor concentrates. Rare complications include skin necrosis and purple toe syndrome. Warfarin has numerous drug, dietary, and environmental interactions, and patient response may be altered by disease states necessitating closer monitoring. Warfarin is contraindicated in pregnancy due to teratogenicity, and heparin or LMWH should be used instead. In summary, anticoagulants must be taken exactly as prescribed. Patients should watch for signs of bleeding, attend required monitoring, and tell healthcare providers they are on anticoagulant therapy. Thanks for watching. Don't forget to like, share and subscribe for more content.